Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our world-renowned distinguished faculty from Japan, Professor Toshio Matsushima. Professor Matsushima is Emeritus Professor at the Saga University, Department of Neurosurgery, Koga Hospital, and ex-professor of Graduate School, International University of Health and Welfare. He also serves as the President of the International Rotan Society. He was a previous courtesy clinical associate professor at the Department of Neurological Surgery at the University of Florida with Professor Albert Rotan, and his clinical expertise is reserved in the surgery of posterior fossa, microvascular decompression, myomed disease, aneurysms, and microsurgical anatomy. He is a noted author with over 100 publications in various index journals, and is also an invited faculty to various workshops and conferences around the world. We are extremely honored to have him today at our webinar, and today we will be talking about surgical anatomical study of the fourth ventricle and evolution of cerebellomedullary fissure opening. The speaker for the second session of today is a shining star from Penn Medicine, USA, Dr. Visish Srinivasan. He is an assistant professor at the Hospital of University of Pennsylvania. Dr. Srinivasan is a comprehensive cerebrovascular neurosurgeon with advanced training in both microsurgical skull-based techniques as well as endovascular techniques to treat cerebrovascular disorders. This includes aneurysms, AVMs, AV fistulas, cavernous malformation, ischemic stroke, intracerebral hemorrhage and subarachnoid hemorrhage, myomed disease and carotid disease. He also runs a translational research lab where he studies and researches cerebrovascular pathologies. He is a noted author with over 250 citations, and we are extremely honored to have him today at our webinar. Today he will be talking about cerebral venous stenting for idiopathic intracranial hypertension. The chair for the first session of today's webinar is our honorable guest and world-renowned neurosurgeon from Istanbul, Turkey, Professor Uygur Ture. He did his training where he studied microsurgery and surgical neuroanatomy at the Zurich Hospital under the supervision of Professor Ghazi Yashergil. And 2005, he established the Department of Neurosurgery at the Yeditepe University Hospital and continues to work as the head of the department there. He continues his work on surgical neuroanatomy and surgical techniques there, and he has authored articles and book chapters in world's leading neurosurgical journals. He has a special interest in the dissection of white matter of the brain, and he has mentored his center into a world-renowned specialized center for white matter dissection courses and research. He has served as the vice president of the Turkish Neurosurgical Association between 2010 and 12, and as the president of Turkish Neurosurgical Association between 2012 and 14. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today is our honored guest from Japan, Professor Shigeru Miyachi. Professor Miyachi is a professor and head of Department of Cerebrovascular and Endovascular Neurosurgery at the Aichi Medical Center, Japan. He is a world-renowned faculty for endovascular treatment of various cerebrovascular pathologies. He has served previously as a president of the World Federation of Neurointerventional Therapists Association, and he has mentored hundreds of neurosurgeons and also pledged his support for the same in both online and offline education courses. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President Professor Yoko Kato, I would like to welcome both the speakers, chairs and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Uygur Ture. Professor Ture, all yours.
Thank you very much. Thank you, Professor Raja. It's great honor for me to join you with this special webinar, and I would like to thank especially to Professor Kato and Professor B for organizing this webinar, Asian Congress of Neurological Surgeons webinar. And it's such a great honor for me to be a chair of Professor Matsushima's lecture. And you summarize his CV, but I like to add something else, because Professor Matsushima played great role in my career. First of all, when I started the residency in 1988, I understand that we have to understand anatomy first, and I find out his paper about the microsurgical anatomy of the veins of the posterior fossa. This changed my career. 42 pages of such a detailed anatomical information. It's not exist anymore in any literature. Unbelievable. And I thought that, okay, only Japanese can do such a paper. It changed my life. And I am interested with the microsurgical anatomy. And then he invited me first time to International Symposium on Microsurgical Anatomy in Matsumoto. This is historical meeting, 2002, because this meeting is I think the first meeting of Roton Society meeting, maybe we have to call, because this idea started in that meeting, and I was lucky enough to be there, and I thank to him. And then he invited me to join the Roton Society meeting. This is very important idea, philosophy, because I was not a fellow of Professor Roton. I am from Yaşargis Mefti School, but he invited me to be executive committee in that society. This idea is very important. We have to come together. We have to bring the different school together and to do better job, better production. And I was lucky enough to be a president of the Third Roton Society meeting last month in Istanbul. And I hope this idea, this philosophy will increase the impact of the International Roton Society and also his contribution of microsurgical anatomy. Professor Matsushima developed cerebellomedullary fissure approach in 1992. I remember that moment, that when I read his paper, and this changed totally. This brings the new era in microsurgery. He involved with the fourth ventricle, posterior fossa, and now cerebellomedullary fissure. I don't want to talk so much. I don't want to take his time. With my great respect and admiration, I would like to invite Professor Matsushima for his lecture. Please, Professor Matsushima.
Yes, thank you very much. Thank you very much, Professor Chure. You said too much for me.
Oh, it's not too much.
I am just one of the Roton's fellows. Yeah, good evening, ladies and gentlemen. I'm Toshio Matsushima from Japan. Before starting my lecture, I would like to express my sincere appreciation to Dr. Raja Chuti and Dr. Yoko Kato for inviting me to this session. Yeah, my today's title is Surgical Anatomical Study of the Fourth Ventricle and Evolution of the Cerebromedullary Fissure Opening Surgeries. I am going to talk about the anatomy of the fourth ventricle and the cerebromedullary fissure and the development of the cerebromedullary fissure opening surgery, especially the trans-cerebromedullary fissure approach, also called Terovero approach. But first of all, I would like to show you importance of the surgical anatomy obtained by dissection of the specimen. I'll show you the example. These are the beautiful illustrations of the left CP angle in the lateral recurrent position. Left illustration from the Japanese textbook and right one from the famous textbook Roton. There are cranial nerves. When you see these beautiful illustrations, you may feel that you understood the anatomy of the CP angle. However, this is a real intraoperative view of the left CP angle. After releasing the CSF through the lumbar drainage, first, we can see only the structures covered with the arachnoid membrane. Can you tell me the names of the structures which are numbered? You have to imagine the structure through the membrane. I place the anatomical slide of the cadaver specimen on the right side. There is a fifth and eighth and lower cranial nerve. And also we can see the cerebropontine fissure. On the medial side, the most protruded structure is the flocculus. The flocculus and the petrosal fissure are the most important intraoperative landmarks on the medial side. Then, first is the eighth cranial nerve. Second is the vein of cerebral-pontine fissure. Third is the jugular foramen. And fourth is the petrosal fissure. To get the practical knowledge, please touch and dissect the specimens. I studied the surgical anatomy at the Roton Lab in the UF 2 times for 3 years. During the time, I worked only in the lab from the early morning until the late evening. I studied the posterior fossa, PICA, fourth ventricle, veins of posterior fossa, and CP angle. I worked on the project of the fourth ventricle in 1980 and published the paper in the journal Neurosurgery in 1982. At the time, I well learned the anatomy of the fourth ventricle and cerebral medullary fissure through the dissection of the cadaver specimen. I show you the anatomy of the fourth ventricle and the cerebral medullary fissure. I'll explain their relationship. First, fourth ventricle. These figures show the mid-sagittal planes of the actual specimen and MRI. The fourth ventricle is a cavity sandwiched between the brainstem and the cerebellum. Its shape is a triangle. The roof is a superior and inferior medullary view. Top of the roof is a fascium. We can see those structures on MRI. These illustrations show the fourth ventricle in which the cerebellum has been removed in part. The left illustration shows its superior view, and the right one does the anterior view. The cerebellum is connected with the brainstem by the 3 cerebellar peduncles. It is easier to understand the structure by the rule of 3, which Dr. Roton always told us. The brainstem is composed of the 3 parts: midbrain, pons, and medulla oblongata. The cerebellum has 3 cerebellar hemispheric surfaces: tentorial, petrosal, and suboctal surfaces. There are also 3 cerebellar peduncles: the superior, middle, and inferior peduncle. In the posterior fossa, most of the structure are composed of the 3 parts. The fourth ventricle is composed of the brainstem and the cerebellum. They are connected by the 3 cerebellar peduncles. Then, there are also 3 cerebellar brainstem fissures: cerebral mesenchymal fissure, cerebral pontine fissure, and cerebral medullary fissure. The cerebral medullary fissure is the biggest of the 3 fissures. In the 3 fissures, the 3 cerebral arteries cause. The SCA, superior cerebral artery, runs in the cerebral mesenchymal fissure. The AICA, anterior inferior cerebral artery, in the cerebral pontine fissure. And the PICA, posterior inferior cerebral artery, in the cerebral medullary fissure. The superior cerebral artery is related to the anterior part of the roof of the fourth ventricle, and the PICA is related to the posterior part of the roof of the fourth ventricle. The floor of the fourth ventricle is composed of the pons and medulla oblongata. Its shape is a diamond. There is a medial sulcus in the center of the floor. The sulcus limitans divide each half of the floor longitudinally. The stria medullaris transversely cross the intermediate part of the floor. We can see the facial colliculi just superior to the stria medullaris. Dr. Kyoshima proposed a suprafacial and infrafacial triangle for the direct approach to the pons in 1993. Next is I'll show you the anatomy of the cerebropontine cerebromedullary fissure. To my knowledge, Dr. Yunpeng Huang, neuroradiologist, is the first person who reported the anatomy of the fissure in detail. He published his paper on the veins of the lateral recess in 1967. Around the 1960s, he studied the fissure to reveal the cause of the vein of the lateral recess. In those days, there were neither CT scan nor MRI. The angiography was the only tool for the radiological diagnosis. This slide shows a step-by-step dissection of the subocular surface. The cerebromedullary fissure is hidden by the subocular cerebral surface. The left tonsil and part of biventral lobule have been removed. Then we can see the cerebromedullary fissure. The floor of the fissure is the roof of the fourth ventricle, which is composed of the inferior medullary velum and terra choroidea. The cerebromedullary fissure is the only entrance to the fourth ventricle without incision of the neural tissues. The fissure is furthermore separated into two uvulotonsillar and medullotonsillar spaces. I will show you the dissection of the fissure using the cadaveric specimens.
Now we are entering the right cerebellomedullary fissure. The fibrous connective tissue between the tonsil and the terra choroidea is being cut. In the bottom of the fissure, a part of the lateral recess can be seen. The biventral lobule is being cut. After removal of the most inferior portion of the biventral lobule, the right lateral recess and the flotulus appear. The posterior wall of the lateral recess is the thick membrane called rhomboid lip. The 9th and the 10th cranial nerves are situated anteriorly to the lateral recess. Here is the foramen of Lucica. Next, the tonsil is removed. As you can see, the tonsil is attached at only one part. It is connected with the white matter of the cerebellum at the anterolateral portion. Now, the supratonsillar space appears anteriorly to the right tonsil. The semi-translucent membrane is the inferior medullary vein. The tonsil is attached at the anterolateral portion. Now, the floor of the right cerebellomedullary fissure is entirely seen. The anterior half of the floor is the inferior medullary vein, and the posterior half is the terra choroidea. The choroid plexus can be seen through the terra choroidea. The terra choroidea laterally extends to form the roof of the lateral recess. The boundary between the inferior medullary vein and the terra choroidea, which we can call terra-velo junction, is easily detached. When the terra choroidea is reflected, the choroid plexus attached to the terra choroidea appears. Let us look at the lateral part of the fissure. This is the most lateral portion of the lateral recess. The foramen of Lucica can be seen, and its flora is made of the rhomboid lip. The 9th and the 10th cranial nerves are situated just anteriorly to the foramen.
The PIC arising from the vertebral artery passes posteriorly around the medulla oblongata and enters the cerebromedullary fissure, which is the posterior half of the roof of the fourth ventricle. While the PIC courses around the fourth ventricle, it makes the caudal loop near the inferior pole of the tonsil and the cranial loop near the fascium. After turning away from the fourth ventricle, it supplies the vermis and hemisphere. Next, I'll talk about the development of the cerebromedullary fissure opening surgery from the historical view. After returning to Japan in 1983, I started my surgery of the fourth ventricular tumors. In 1990, I encountered the unforgettable case of the ependymoma. This case taught me a lot. The tumor occupies the entire fourth ventricle and extended inferiorly to the level C2. In the first surgery, I utilized the transvermian approach, which was a regular approach to the fourth ventricle at the time. I believed I removed the tumor totally. However, the tumor recurred in the left lateral recess 1 year after the first surgery. I operated again and removed the tumor from the left lateral recess. From this case, I learned that I should have observed the lateral margin of the ventricular tumor. That meant observation of the lateral recess. After this beta experience, I started to dissect the cerebromedullary fissure sufficiently to remove fourth ventricular tumor completely without leaving the tumor in the lateral recess. Opening of the fissure was very useful for the fourth ventricular surgeries, like the opening of the Sylvian fissure in the trans-Sylvian approach. This was the beginning of the trans-cerebromedullary fissure approach. Since we already had MRI in the late 1980s, I also studied the anatomy of the cerebromedullary fissure on MRI and reported the first paper on the trans-cerebromedullary fissure approach in 1992. In the paper, I reported 4 representative tumor cases in which the tumor was removed through the trans-cerebromedullary fissure approach. In the right row, the case of cavernoma is demonstrated. Transvermian approach requires the incision of the inferior vermis. The incision of the vermis and the lateral retraction of the dentate nuclei have sometimes been implicated in so-called cerebellar mutism syndrome. After starting the cerebromedullary fissure opening, we did not have any cases in which the vermian split syndrome occurred post-operatively. In 1997, Kellogg et al. Reported that the cerebromedullary fissure approach did not cause post-operative vermian splitting syndrome, with good surgical result of their 11 cases. In 2000, Musi and Lawton presented a beautiful cadaveric demonstration of the fourth ventricular exposure through the cerebromedullary fissure opening in the midline approach. They called it the Terobello approach. This report made a significant contribution to the spread of this approach. The following year, in 2001, we reported the medial type of the approach with 3 different opening types. extensive, lateral wall, and lateral recess types based on our surgical experience of 19 cases. As a result of such circumstances, the opening procedure of the cerebral medullary fissure in the midline has two names, transcerebral medullary fissure approach and pteroberal approach. It makes us a little confused. The medial route of the transcerebral medullary fissure approach is a pteroberal approach by Dr. Musi and Dr. Wharton. Now, I sometimes use the word transcerebral medullary fissure / pteroberal approach. Some tumors in the fourth ventricle extended inferiorly and laterally through the cerebral medullary fissure. Therefore, opening of the cerebral medullary fissure is able to be done in two directions. We can approach the fourth ventricle not only from the medial side midline, but also from the lateral side. The transcerebral medullary fissure approach has two routes, medial and lateral route. First, I'll explain the medial route. The medial route means the transcerebral medullary fissure approach from the midline after midline subocular craniotomy. Next is how to open the cerebral medullary fissure efficiently to obtain the wide optical field. First, dissection of the fissures around the tonsil, ubrotonsillar and medullotonsillar spaces. Second, incision of the pterygoidea, especially the tinea from the foramen majandi to the foramen brusca, to open the roof of the lateral recess. The incisional line is indicated by blue and red arrows. Third, retraction of the tonsil in the superolateral direction. Fourth, same procedure on the contralateral side. I'll show you how to open the fissure using the video. The case is of the cavernoma in the pons. CT scan shows a hemorrhage in the pons. The wide midline subocular craniotomy was done. Bilateral tonsil and the left PICA. The right tonsil is being lifted up and the right middle tonsillar space is being opened. Now we can see the interior of the fourth ventricle, foramen of majandi and pterygoidea. The tinea is being incised from the foramen majandi to the ventricular entrance of the lateral recess. There is a stray medullaris. Lateral recess is opened, and then the interior of the recess is further exposed, right side. Thanks to the opening of the fissure, the floor of the fourth ventricle is widely exposed. Now checking the facial curricula. There was a bulging in the suprafacial triangle. We puncture the bulging and remove the cavernoma. We can approach anywhere of the fourth ventricle. This is another case of the cavernoma, located in the upper pons deep near the cerebral aqueduct. We are able to remove it through the almost complete opening of the cerebral medullary fissure in 1996. We started to call the approach transcerebral medullary fissure approach. I'll show you how to remove the fourth ventricular tumor through the medial route. This is a case of the ependymoma. The preoperative MRI demonstrates the tumor extended not only inferiorly, but also laterally, especially to the left cerebral medullary system. During the surgery, we had to confirm the lateral margin of the tumor inside the lateral recess in order not to leave the tumor in the lateral recess. The transcerebral medullary fissure approach is very useful for removal of the tumor in the lateral recess. I'll show you the removal of tumor in this case, step-by-step procedure. A tumor extends inferiorly between the tonsil like the tongue. Under the tumor, the caudal loop of the PICA is found. First, this extraventricular tumor has been resected. The area surrounding the obex, the large left veins of the inferior cerebral peduncle is present. The tumor is being dissected from the fourth ventricular floor, the medulla oblongata. The dissection is done very carefully. A yellowish thin tissue is left to the floor. The right tinea is being followed to the ventricular entrance of the right lateral recess. The right lateral recess is occupied with a tumor. The lateral recess has been opened. The right lateral margin of the tumor was confirmed. The tumor originates from the right lateral wall of the ventricle. When the originated portion is incised, a large ventricular tumor is able to be pulled out. After removal of the tumor, entire of the floor and dilated cerebral aqueduct are seen. However, the operation is not finished yet. Last, we are checking the left lateral recess. The tumor is still present in the left lateral recess. The tumor in the left lateral recess is being removed. Now tumor is pulled out from the lateral recess. Now the tumor removal is completed. The post-operative MRI revealed total removal of tumor. The patient has been doing well without any neurological deficit. This is a recurrent case of the medulloblastoma, which was introduced to us. The tumor recurred from the left cerebral medullary system to the prepontine system. When a part of the tumor was left in the lateral recess, the tumor recurred in the prepontine system. We have to remove the tumor in the lateral recess at the first surgery. Next, lateral route. The lateral route means the transcerebral medullary fissure approach from the lateral side. After the lateral foramen magnum approach, the procedure involving almost complete opening of the unilateral cerebral medullary fissure provide a wide surgical field in the cerebral medullary system and enable a gentle cerebral retraction. Unilateral opening of the cerebral medullary fissure is very useful for the OA-PICA bypass surgery, MVD for the gross pharyngeal neuralgia, and removal of some tumor in the cerebral medullary system, such as the jugular meningioma or choroid plexus papilloma. We call the approach unilateral transcerebromedullary fissure approach. This is a case of the VA-PICA aneurysm. Aneurysm at the origin of the PICA was trapped after the OA-PICA anastomosis had been performed. The left cerebromedullary fissure was sufficiently open for the bypass procedure. This slide shows a typical procedure of the MVD for the gross pharyngeal neuralgia. Its surgical approach depends on the offending arteries, such as AICA or PICA. In most of the cases of the gross pharyngeal neuralgia, the PICA with the high origin is the offending artery. It often forms an upward loop. The upward loop of the PICA, which is guilty, is being pulled out posteriorly and fixed to the dura mater. I'll show you a typical case. Left slide shows the MRI and MRA. Right PICA makes an upward loop in the supraolivary fossette. 3D CT scan is very useful to imagine the intraoperative view. Right low slide shows the intraoperative finding. The right PICA makes an upward loop below the lower cranial nerve, compressing the gross pharyngeal nerve. I'll show you the surgery this case. First, I perform the right transcondylar fossa approach. The right condyle and the condylar fossa are visible. Condylar fossa is being removed and the dura mater is opened. The posterior part of the right cerebromedullary fissure has been opened, and the posterolateral portion of the cerebral hemisphere has been lifted. You can see the PICA coursing along the tinea of the fourth ventricle. In the cerebromedullary system, the PICA and 12th cranial nerve began to be seen. The PICA is being detached from the lateral recess. Now we can see the whole lower cranial nerves. The upward loop of the PICA and AICA goes between the 9th and 10th cranial nerve, and both compress the gross pharyngeal nerve. Once the AICA was transposed upward for decompression. And then the loop of the PICA has been also pulled out posteriorly for decompression. The pull-out loop of the PICA has been fixed to the dura mater with a stitch sling retraction technique. The transposed AICA was also fixed to the cerebral cortex by glue. Decompression of the both offending artery is completed. This is a case of the choroidoflex papilloma originating from the right lateral recess. The tumor was located in the right cerebromedullary system and right cerebromedullary fissure, mainly in the lateral recess right side. It was removed through the lateral route of the transcerebral middle fissure approach combined with the transcondylar fossa approach. I'll show you the video of this case. Midline subocular craniotomy combined with the right lateral subocular craniotomy is done. A round tumor appeared in the right cerebral medullary system. The right PICA runs around the tumor. When the tumor is compressed laterally, we can see floor of the fourth ventricle. Choroid plexus in the right lateral recess is visible, and we confirm that tumor originated from the choroid plexus. When the tumor is being lifted, the right vertebral artery is found. There are 12 cranial nerve courses on the artery. The tumor boundary from the surrounding structure are clear. We are able to remove the tumor almost totally. Only a tiny part strongly adherent to the AICA is left. Post-operatively, new neurological deficit did not appear. And furthermore, the symptom due to the hydrocephalus disappeared. In this case of the jugular tubercle meningioma, unilateral opening of the cerebral medullary fissure is also very useful. Now the transcerebral medullary fissure approach has a variation. The illustration shows the 4 different regions approached through the transcerebral medullary fissure approach. I use the approach to various kinds of regions in the cerebral medullary fissure, in the fourth ventricle, and in the cerebral medullary system. The left slide shows the illustration of the distal PICA aneurysm, which is located in the cerebral medullary fissure. We just open the fissure and follow the PICA to clip the aneurysm. I'll show you another aneurysm case operated on through the combined approach. A 6 mm unruptured circular aneurysm was located at the junction of the VA and PICA. First, interventional therapy was tried, but was not completed because the PICA originating from the aneurysm neck. The patient was referred to us for direct surgery. It had a brave tooth. I made a bony opening for the combined approach of the transcerebral medullary fissure approach and transcondylar fossa approach to obtain a wide operative field and clip the neck of the aneurysm from all directions. First, I'll open the left cerebral medullary fissure. Left tinea is being incised from the foramen of Majandi to the left lateral recess. Uvulotonsillar space is also open. After opening the fissure, the left cerebral hemisphere is being lifted up. Then the left cerebral medullary system was exposed. The lateral recess is furthermore being inside. Now we can see the aneurysm. The PICA originated from the aneurysmal neck. I performed the neck clipping, paying attention to the origin of the PICA. The intraoperative ICG examination reveals the patency of the left PICA. This is a final view. The post-operative three-dimensional computed tomography images demonstrate complete clipping of the aneurysm. After 1 month rehabilitation of the swallowing, the patient was discharged without any symptoms. Conclusion of the cerebral medullary fissure opening surgeries. First, the anatomy of the cerebral medullary fissure was explained, and the way to use the opening of the fissure, that is a transcerebral medullary fissure approach, was also explained. Second, in the approach, the fourth ventricle and its surrounding areas are widely exposed without any incision of the neural tissues. The development of the cerebral medullary fissure opening surgery was reviewed historically. It was emphasized that the approach has a few variations, such as a medial and lateral route. The combination of the, I wrote the transcerebral medullary fissure approach and its variation in my textbook on the surgical anatomy and surgery on the posterocranial fossa from the Springer. Dr. Rotom, my teacher, told us the combination of the knowledge of the microsurgical anatomy and the use of the operating microscope has improved the technical performance of many neurosurgical procedures. Thank you for your attention. Thank you.
Thank you, Professor Matsushima, for excellent, very didactic, very clear presentation. I thank you so much. It's always we are learning from you. Now I think we are open for the questions. So please, Dr. Raja, can you help me that how we can choose questions?
We can invite comments from our honorable panelists. First of all, let me thank Professor Matsushima for this very, very wonderful lecture, and it was like a revision from my residency. Thank you very much. So you showed very beautiful demonstration of various pathologies in the after opening the cerebellomedullary fissure. Among them, one was a case of epingeomoma that showed, and you have beautifully demonstrated it. One question we have often noticed in our practice that when the tumor is stuck to the floor of the fourth ventricle, as you see on the preoperative MRI, there is some hypodensity in the brainstem where the tumor is attached. It means the tumor is firmly adherent to the floor, and if you try to remove that, often we have seen that patient lands up in a very bad post-operative condition. What are your tricks that you can give us to facilitate this smooth removal of the tumors from the floor of the fourth ventricle?
Yeah, you are talking of the origin of the tumor. So we have now the, enhanced MRI, but it is not exactly we can understand before the surgery. Maybe, we can know suspected portion. In the case of the ependymoma, tumor originated from the lateral wall or the floor. But in the case of the medulloblastoma originated from the roof of the fourth ventricle. So in the case of the medulloblastoma, you can cut inside the a little vermis. But in the case of the ependymoma, we don't need to incise the vermis. I show the one case, surgical case, but attachment is not so wide. So we need to attack the attachment. Then inside the attachment, original portion, then we can pull out the ependymoma. But sometimes tumor extend into the lateral recess bilaterally. And in the midline approach, we often miss the presence of the tumor in the lateral recess. Midline approach, especially transvermial approach, is not good for the looking at the lateral portion of the fourth ventricle. So I started to look at the lateral portion after opening of the cerebromedullary fissure. I cannot exact correct answer to you because the origin is still, but we can understand the suspected portion on the enhanced MRI.
Thank you very much. And we can invite comments from our honorable panelists. Dr. Vishesh, would you like to ask something?
Less of a question, but just a general thanks and comment. Just as you said, Dr. Raja, this was like your classic articles that you wrote with Dr. Roten were amongst the ones that I read early in my residency. And in my first, we had in my residency, it was called a resident seminar. So at the PGY3, you had to take a 1 hour topic or take some sort of topic of interest and give a 1 hour lecture on it. And this was my topic, was the anatomy of the cerebellum and the telovelar approach. So many of these slides that you used, it was great to see from you, Dr. Matsushima, because this is a topic that I particularly enjoy and I'm very fond of. So thank you.
Thank you
very much. Yes, my co-host Liu.
Thanks, Raja. Thanks, Professor, for very nice lecture, Professor. I wonder, Professor, I had a case with hemangioblastoma of inferior cerebellar peduncle, inferior part of it. If we use a cerebellomedular fissure opening, which one would be better? More medial or more lateral approach, which are more direct to the area. My second question, Professor, for a tumor that extending beyond aqueduct or CVS, how do you remove the tumor completely? Originally in the fourth ventricle, which extending beyond aqueduct or CVS. What is the best approach, Professor? Thank you.
Sorry, I couldn't hear the question. Raja?
Well, Professor Ture is the right person if he understood the question.
Yeah, I mean, I think Professor Matsushima explained this. I think the midline incision and opening the cerebellomedullary fissure and medial and lateral part, and you are there. Professor Matsushima, he asked the question to remove the hemangioblastoma in the inferior cerebellar peduncle, isn't it?
Yes,
in the case of the hemangioblastoma, usually located inside the inferior cerebellomedullary fissure. So just follow the, if the feeding artery is a PICA, you can follow the PICA and, you know, not so difficult in the case of the medium size of the hemangioblastoma near the distal pica annulus. Do you understand my?
Yeah, it's clear, Professor Matsushima. It's clear.
Right.
So
Thank
may I
you.
have some questions, Dr. Raja?
Please, please.
First of all, again, I thank you, Professor. I understand that you prefer midline incision in all of the cases. Is it correct? You do midline
No,
incision and then go laterally, or how you choose the incision, and then the position. You use always prone position or also sometimes lateral position. Would you explain a little? I was not sure with the videos.
now I'm using the lateral position. But
Lateral.
yes, lateral position. But 20 years ago,
Yeah.
20 years ago or 30 years ago, when I started this approach, prone position is easier for me to understand the anatomy. So first 10 years, I prefer the prone position. And also, incision is most of the cases is a midline incision, but always extend laterally to the U shape on the unilateral.
Unilateral.
Yeah.
So, for example, for pica aneurysm,
Mhm.
which incision you prefer now, today?
Today, usually pica aneurysm, I'm going the lateral incision. But the case which I show you the last case, aneurysm originated from the origin of the pica. Interventional people did not complete the procedure. So I am not sure I can do that. So I need to the direction for the clipping from all directions. So I made a midline incision and U-shaped, and then I perform the left transcondylar fossa approach, far lateral approach, and midline approach. Then I'll obtain the all direction for the clipping.
I mean, I agree with for pica aneurysm now, I prefer midline incision and go lateral, and you have more better view in the neck of the aneurysm, and I was impressed with your video. So
yeah,
yeah.
But you remember 20 or 30 years ago, we discussed about the very distal VA aneurysm, pica aneurysm, high origin. Maybe aneurysm is located anterior to the medulla oblongata.
Yeah.
That's why we perform the far lateral approach, transcondylar approach.
Yeah.
But regular situation, you are right.
I agree with you. So there are some cases that it's very anterior to medulla oblongata, and then you can do lateral. But the standard pica aneurysm in for me today, I prefer midline incision that can open the cerebellomedullary fissure laterally. You just show beautifully. But you never use semi-sitting position, isn't it?
Yeah. When I was a resident, I used to use, but we had an air embolism.
Yes.
Then we stopped at my university. In the case of Dr. Wharton, when I started my fellowship at the University of Florida, he was doing the acoustic tumor surgery in the semi-sitting position, but he also had an air embolism. Then he quit the semi-sitting position.
And I have last comment that I have to mention that, Yang Peng Huang is his paper is unbelievable. They describe this anatomy. And I was in Zurich in 1990 in September. And I have to mention that Professor Yaşargil was he never cut the vermis. He was opening the uvulotonsillary fissure. Actually, there is no name of that fissure. The fissure between the uvula and tonsil, and just follow the pica, and he go to fourth ventricle. So I like to mention that he was not opening totally cerebellomedullary fissure, but he was opening the uvula and tonsil fissure, and then he went to the fourth ventricle, and I was doing the same when I returned back to Istanbul. But the opening whole fissure is, of course, shows wider exposure. But just I have to mention historically that Professor Yaşargil was also never cut the vermis.
Yeah.
I thank you for your excellent lecture, Professor.
I read the Dr. Yaşargil's books.
Yeah.
And
published late. Yeah.
Today, I didn't mention several authors who opened the cerebellomedullary fissure partly. 30 years ago, many several authors described, like the Shaker group, describe the part of the opening of the cerebellomedullary fissure. But today, in my lecture, I didn't mention those authors. Sorry.
Thank you very much.
Thank you. Well, Professor Mathuria has joined us. Would you like to ask something, Professor Mathuria?
Oh, actually, it's a beautiful demonstration of a technique which used to be practiced in past through the vermis, and obviously through the vermis when the things were removed from the floor of the fourth ventricle, it used to cause the mutism, which obviously is not there with this approach. And he has described about the various locations of the tumor, medially located, then the medial part of the approach, the lateral and anterolateral, about the lateral part of the approach, and removal of the condyle, and further going laterally and anteriorly. It's really a beautiful thing. And it has already been described earlier that it is like opening the sylvian fissure for the aneurysms. As you open the cerebellomedullary cistern and go there, without disturbing any part of the brain tissue, it's an excellent approach to deal with. And
we are talking of the opening of the cerebellomedullary fissure.
yes.
But actual procedure is cut inside, cutting the tinea from the foramen majandi to the ventricular entrance of the lateral recess. Cut the terracoroidea, lateral edge of the terracoroidea tinea. Then you can lift up the terracoroidea.
And what I wanted to tell you is that as you have done dissections in the lab of Professor Albert Rotten, similarly, when the people who has got the cadaveric dissection lab, as we also have at our place, then we can give this topic to the people to work on it. The students can work, and then they can develop on this approach far better than what going straight on to the one of the panelists have asked a question, probably you couldn't understand. The thing is that if there is a tumor which is going above the level of the aqueduct, is it possible to approach through this approach? Could you follow now? Professor Matsuchino.
Aqueduct.
I never seen.
Oh.
You mean the extend into the third ventricle, fourth ventricle extend into the third ventricle through the directed to aqueduct.
Yes.
I have never seen. I don't
Oh.
know. Maybe,
I
maybe
have-
we
I
can.
have cases that I removed the aqueduct tumor through fourth ventricle. I have 3 cases.
Is that right?
Yeah,
Maybe
the
we can
inferior
use-
aqueduct tumor. Inferior aqueduct tumor, you
Mhm,
can remove it from below.
mhm. Maybe now, we have a endoscope. So aqueduct is dilated. We can use the endoscope. I think
No,
so.
actually, the thing is that as you have shown that the tumor is attached in the lower part only, and if it is going above that level, then probably the tumor will come down as the attachment is already cut, as you have described in the approach.
Yeah.
Professor Ture, that's what you wanted to tell, that if the tumor is going above and the attachment is below, attachment, Professor Matsushima has already described that we have cut the attachment, then the tumor will come down.
But I mentioned that my cases, tumor was originating in the inferior aqueduct.
Okay, then it's a
And
different.
this is different. So it's going to be published in Journal of Neurosurgery soon. So
So-
inferior aqueduct tumor, you can remove from fourth ventricle.
Okay, nice.
Right. Well, thank you, everybody. I think we
Thank
had
you
a
so much.
wonderful discussion and absolutely wonderful lecture from Professor Matsushima. And I would like to thank both the speaker and chair for this wonderful session. I would like to also inform our viewers that this webinar is broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 1,250 people who have joined from all over the world to view this live. So we are extremely grateful to Professor Shubin for that. And now we'll move on to the second session.
Thank
So
you very
we'll
much.
hand this
Bye-bye.
session over to our second chair, Professor Shigeru Miyachi, who will say a short introduction and invite Professor Vishesh Srinivasan for his lecture. Professor Miyachi, all yours.
Thank you, Raja. It is a great honor for me to chair Professor Srinivasan. A short introduction before his lecture. Professor Srinivasan ran basic neurosurgical techniques in Barrow Institute, and he's an expert of direct surgery for cerebral vascular diseases, as well as pediatric and skull-based regions. As well, he has a lot of experiences of neuroendovascular treatments for various entities, particularly embolization of aneurysm, flow diversion, thrombectomy, and stenting, etc. So he's a multi-talent neurosurgeon, so-called hybrid neurosurgeon. So familiar with the direct and endovascular approach. And his topic is idiopathic intracranial hypertension. That is one of the hottest topics now. And the pathophysiology of this disease has been unclear for a long time. In the former days, it was called pseudotumor cerebri. To release the intracranial crisis, surgical decompression, optic nerve sheath fenestration, bariatric surgery has been done, but all of them were not so effective. Ventricle peritoneal or lumbar peritoneal shunt has been one of the most reliable way, but symptoms sometimes recur. So under such a background, endovascular dural sinus stent placement is a breakthrough therapy, and it brought about a dramatic improvement. I also reported 2 cases with perfect recovery after stenting 5 years ago. So today, Professor Srinivasan will talk the remarkable effect of stenting. Professor, may I ask to start your lecture?
Thank you. Thank you for the kind introduction, Professor. Glad to share. Hopefully you're seeing my slides. Thank you once again to the ACNS and everyone for the introduction and for the invitation. So I'm Vishesh Srinivasan. I'm a neurosurgeon, both open and endovascular at University of Pennsylvania in Philadelphia in the US. So just as background, I started my kind of academic career here in Philadelphia at Drexel University. I went there for college and medical school. I did my neurosurgery residency at Baylor College of Medicine in Houston. These were some of my professors. Dr. Yosher was my chairman, who's also now my chairman at University of Pennsylvania. And primarily my endovascular and vascular education was from Dr. Burkhardt, who gave a lecture here recently to the ACNS, and Dr. Peter Can, who trained me both in the laboratory and surgically. And then I did my advanced fellowships in both endovascular and cerebrovascular neurosurgery with Dr. Lawton for the open side, and then Dr. Philippe Albuquerque, Dr. Ducre for endovascular. So I'm here now at the University of Pennsylvania. This is our kind of new hospital. You can see a little bit of new and old. So to the right side is the old hospital. The hospital, the University of Pennsylvania is, I think, the second oldest hospital in the U.S. It is the oldest academic teaching hospital in the U.S. And then to the left is our new building. This is where I practice now, but kind of keeping it a little bit in the old style. So even though it looks to the future, it looks futuristic, it still keeps the color and style of the old a little bit. And then just behind there, that silver building you see is where my translational research lab is. And we're right here within the city of Philadelphia. So we have 3 neurointerventional suites. This is where I primarily practice. This is the Siemens Icono system. This is what we use for our procedures. And I'll obviously show some recordings from our operative procedures. So both of these are 2 mirrored suites. Those are my fellows. And this is where we perform the majority of our endovascular procedures. And then down the hall, we have an additional suite. This is primarily for open cerebrovascular procedures, but you can see it looks very similar. This is just the same system, but with additional equipment, microscope and endoscope, et cetera, allowing us for hybrid open procedures. And essentially all of my open cerebrovascular procedures, I also will do intraoperative angiography, and we have a lot of opportunity for advanced imaging. And that was the topic actually of my partner, Dr. Burkhardt's lecture a few weeks ago. So we are talking about so-called pseudotumor cerebri, or as I prefer to call it, IIH, for idiopathic intracranial hypertension. That's the preferred terminology now. This was discovered back in 1893 by a German physician, Professor Quincke. And since then, we have kind of come really a far way in our understanding of the physiology, but truthfully, it is still incompletely understood. These are some excellent slides that I picked up from Dr. Pierre Gobin, who is from Cornell, and also a researcher with a significant interest in IIH. So there's so many different symptoms and signs that you can see from venous sinus stenosis, whether from IIH or otherwise. And you can see that we can kind of start to build both a visual and a mental model of what do we see when we see these patients in the clinic. Well, the classic triad that we see is one of visual field loss, which you can see here. This is a smaller proportion of patients, and many times more common is papilledema, which you see in this yellow circle. So you can see that this overlaps. There are people who will have visual field loss. The majority of them will also have papilledema, but there are many more people who will have papilledema without having visual field loss. And then there's a small proportion of people who will have field loss without papilledema. Then you can overlap this additionally with what you see here in the gray circle, opening pressure. So high opening pressure is seen really in the majority of patients with venous sinus stenosis. And we expect that to be greater than 25 centimeters of water in obese patients, and then slightly different at normal weight. And you have to remember that this opening pressure will be relative to the patient's overall obesity and how their body mass is constructed. Also, about 25% of patients will have very severe acuity loss. and blindness. And then 3% of these cases, IIH cases, will progress very rapidly in what's called a fulminant course, where from onset to near blindness can be very, very accelerated. And so these are the patients that really need to be seen and worked up as an inpatient and rather than as an outpatient setting where they may go months without being able to see someone specialized like a neuro-ophthalmologist. We add in headaches into this visual model where most patients will have headaches, but it's certainly possible to have silent papilledema without headaches, or headache in the setting of high opening pressure, but not visual field loss. We add in some of the other, call it vaguer symptoms, or symptoms that have much more overlap with other diseases. So this includes chronic fatigue, loss of libido, cognitive impairment, mental fog, dizziness, nausea. I also see some of these overlapping symptoms, for example, in patients with moyamoya disease, where they don't have full-on ischemic strokes, but the chronic hypoperfusion, especially in the frontal lobes, will give them a lot of this cognitive impairment. We can add in pulsatile tinnitus. This is somewhat separate from the classic IIH patients. Many IIH patients will have pulsatile tinnitus, but totally possible to have pulsatile tinnitus and then not have any of these kind of visual, general increased intracranial pressure types of symptoms. And then last, something that we're really starting to understand now is cerebrospinal fluid leak. We do see that this is a little bit on a continuum with the types of patients that we have seen classically that have Tegman defects or other symptoms that we see of empty sella and rhinorrhea, et cetera. So this is the state of, as Professor Miyachi mentioned, this was the state of IIH understanding when I started in residency. So this was my now chairman, or then chairman also, Professor Yosher, wrote this review with some of our general surgeons and neuro-ophthalmologists at Barrow talking about bariatric surgery for IIH. And it was essentially mentioned every time I got a consult as a junior resident. It was, well, we are going to try not to shunt this patient, but rather have them see bariatric surgery as the first line. And additionally, if they have optic symptoms, then push them to the ophthalmologist to do optic nerve sheath fenestration, and then only then will we consider shunting a patient if they've failed weight loss, and then we would consider either an LP shunt or a VP shunt. It was really like trying to push these patients off as much as possible. This is the classic patient that we imagine when we think about IIH, right? There is a 20-to-1 ratio between women and men. It is the incidence is 1 to 100,000 in the normal population, 20 to 100,000 in obese young women. So that's the classic patient we think of. And this is the range of obesity amongst different IIH cohorts, anywhere from 70 to 95. But we have to remember that non-obese patients can develop IIH. So as much as we keep that mental model of what an IIH patient looks like, remember that as we start to see more and more of these patients, we have to remember that not every patient reads the book and follows that. So that's generally what I'm going to mention about IIH, and I'm going to dive very quickly into venous sinus stenting. But this is a neurosurgical lecture after all, and especially following in the footsteps of the prior lecture, I want to give respect to Professor Roten and a mention of microsurgical anatomy. And the goal of studying this microsurgical anatomy is to turn what is delicate, fateful, and awesome for our patients into something that is accurate, gentle, and safe. Now, this applies as well when we go into the neuroendovascular field. So as neurosurgeons, we don't need to give up what we've learned for many years in our microsurgical anatomy when you start treating patients endovascularly. It is just an extension of the same concepts with the addition of new radiological concepts, but it's the same concepts, and we need to remember our anatomy as well. So this is, of course, from Professor Roten's textbook, the Cerebral Veins, Chapter 4. And I read this chapter frequently, even in my practice being heavily endovascular. I still look to this very frequently. This was a paper that was recently published. We actually cited and included this beautiful illustration of the deep veins. And so, of course, Professor Roten wrote this with the intention of discussing the deep veins that we see during skull base and brainstem approaches. and that those same anatomic concepts apply. In this particular case, I was talking about the treatment of dural arteriovenous fistulas through the deep galenic system. So in the same way, we need to remember our microsurgical anatomy as we go into treating these venous disorders. And so here are all the cerebral veins. They really don't get nearly as much attention as the arteries, both in endovascular discussions, where majority focus is on the arteries, and in microsurgical as well. And so we just need to make sure that we are understanding our anatomy appropriately before we go to taking care of these. Now, how does that come into play? Well, the theory was developed that restricted outflow through the cerebral veins is going to cause a venous backflow, and then eventually increase the venous pressure in the brain and the overall intracranial pressure. And this is just an extension of the Monroe-Kelly doctrine that the skull is a fixed box, and really there's only space for blood, parenchyma, and CSF. And as the blood volume increases in the head from venous outflow constriction, that's just going to increase ICP. And so what we see is that as high as 90% of patients with IIH will have some radiographic venous sinus stenosis. Now, whether that radiographic stenosis results in actual increased ICP in a physiological sense, that needs to be evaluated. So it's not just about the individual focal stenosis, but actually what I would call functional stenosis. And we'll get to that. But it's important to know, if you look, and if you look carefully, you will see it in almost everyone. So this is the first article that really mentioned cerebral venography and manometry in this patient population of IIH. So what they found was essentially this prior fact: nearly everyone with IIH had some radiographic stenosis, and they noticed in the manometry that it correlated very well with the opening pressure seen on lumbar puncture, and that they were able to identify gradients of pressure, both proximal and distal, to the stenosis. So what we see in IIH is this vicious cycle. It's a positive feedback loop, and this is a hypothesis, but does seem to correlate with our actual practical experience, and we have some objective data for this. But in IIH, what we see is that they have still idiopathic intracranial pressure, right? We don't quite understand what that is, and it still doesn't mean that bariatric surgery doesn't work, because that underlying issue of obesity, especially truncal obesity, increases abdominal pressure, increases venous pressures overall, and that leads to the initiation of this vicious cycle. So then what we see is high intracranial pressure pushes down on the cerebral veins. These are dural venous sinuses, and so you can cause extrinsic stenosis upon the veins by that intracranial pressure. That extramural compression leads to congestion and elevated superior sagittal sinus pressures, or overall pressures proximal to that upstream. And then you get more compression, more venous sinus stenosis, increased pressure. So this is a vicious cycle that keeps getting worse with time. And that's generally what you tend to see in these patients, is they've had, IIH, and they might have had some recent weight gain, and then you see a progressive sense of worsening of their symptoms, whether it's the headache, whether it's their vision, or pulsatile tinnitus, etc. So this was right around the same time that you see this 1995 paper, actually published just before that out of Stanford, was this initial discussion of stent placement for venous sinus stenosis. And this stent placement was actually talking about stent placement across different pathologies. But within that, one of the things that they talked about was venous sinus stenosis, and that was their figure here. You can see the ribboning of the transverse, lateral transverse sinus to where the transverse sigmoid junction here, which was treated by a stent. Now remember, 1994, this was very, very early on in what we had in our technical capabilities for accessing the venous system, as well as the trackability of various stents, and frankly, what devices were even applicable. So fast forward 15 years from then, this was the first major long-term report of venous sinus stenting for IIH. So in 2010, this was about 50 patients. This was written by the Barrow Group, including Dr. Albuquerque, who primarily taught me how to do these procedures. And this was a major report showing what are the different indications and the technique and what the results are. And just summarizing what we saw in this report was remarkable improvement in most patients. About somewhere at 80 to 90% of patients are getting some symptomatic improvement, whether it's their headache, pulsatile tinnitus, or papilledema, with all of those being relatively successful and good long-term durability in the 90% range. Impressive safety as well, with somewhere around a 2% major risk, very similar to some other such procedures. And we found that the presence of a gradient as seen by manometry was most predictive of whether people would improve. Now, for the patients, this is what it looks like. They have some symptoms, they present to medical attention, they may or may not get diagnosed, they get bumped around, they go from their primary care physician, family physician, to perhaps going to the hospital. They wait months and months, at least here in the US, even for a neurology or a ophthalmology appointment. Then that eventually lets them get into a therapeutic tap. So they get a lumbar puncture. So it's this very, very loop-de-loop. So it's not this single line through, but they're getting sent to a specialist, back to another specialist. And it's a very difficult diagnosis for them to go through before they eventually come to a neurosurgeon who's able to offer them multiple things. We can offer them to do an easy lumbar puncture, and then we can also diagnose it. And whether they need CSF diversion as their therapy, venous sinus stenosis, venous sinus stenting as their therapy, or whatever it may be, that's a very difficult procedure for them to, go through all of these various iterations while they have ongoing or progressive symptoms. So the first step to the diagnosis is usually a lumbar puncture. And before doing a venous sinus stent, I usually, if they have not had this, will do this myself in the interventional suite. And if they have had it, it's usually done by a neurologist as an outpatient. And so they get a spinal tap, usually take off 10 to 20 cc's of CSF and see if they have improvement. But this is not quite as simple as you may perform these procedures already for, let's say, a patient with normal pressure hydrocephalus, or a lumbar puncture for any other indication, because the issue that they have of high pressures eventually leads to CSF leak. And so many of these patients have over drainage or a persistent CSF leak after a lumbar puncture, and may require subsequent blood patching. So if you're going to do this, it's generally worthwhile to, one, do it under fluoroscopy if you have that capability, because even though it's very easy to do a spinal tap, and all of us have done hundreds or dozens of spinal taps without the X-ray guidance, these patients are generally obese, and it may be quite a bit more difficult to do these procedures for them, or you might need longer needles, etc. And then also the risk for eventually forming a leak from the needle puncture should be considered. Now, I also usually do some sort of non-invasive imaging just to help guide me and help to counsel the patient whether or not this is something eventually needing stenting is likely. However, there are plenty of false negatives. So many patients who have a lack of venous sinus stenosis on MR venogram or CT venogram may actually end up having something that you see on DSA. So here's an example. In this particular patient, they had internal jugular vein stenosis around this level of C1, and this is also seen. But when you do the venogram, you can see that there's tandem stenosis in multiple levels. That's something that you really need to identify on the venogram. So this is generally what you should expect with doing the LP, is that at slightly elevated pressures, so patients who have, let's say, 24 opening pressure, only about a quarter of them will have pathologic stenosis. Will you see a venous gradient when you do the venogram? However, as it gets higher and higher, when you have an opening pressure of 35, or I think my record is like 55 that I've seen, when you have these super high opening pressures, those patients are almost guaranteed to have some pathologic stenosis. And so when they come into your clinic and they've already had that, you can counsel them that indeed they are headed down the road to a stent. So as I mentioned, this is my room that I do most of these procedures. It's very convenient to be able to offer the patient all of the options. So what do all the options include? Well, that includes doing the LP, that includes lumbar puncture, LP shunt or a VP shunt, and then a venous sinus stent as needed. So the only thing that I wouldn't be able to offer in this suite is an optic nerve sheath fenestration, which the patients who come with primarily visual loss and very severe visual loss are usually referred to me by my neuro-ophthalmology colleagues and have been considered for that procedure already. So here's what the venous manometry looks like. So in the venous manometry, what I do is I do a standard diagnostic angiogram. So I go transradial through the radial artery and do a standard arteriogram. And then I look for the distal venous outflow through all the vessels. So I want to understand what is the dominance of the two systems and what is the overall flow like. Is the patient using some adjunctive or collateral flows, let's say through the suboccipital venous plexus? Then I also will do a venogram. So I go through the venous system. I'm doing direct injections in the dural venous sinuses. So for example, here we're injecting in the medial transverse sinus and seeing what the outflow looks like. And by doing these microcatheter injections in the venous sinuses, I can see some of these more subtle narrowings within the sinus. And then I'm also doing venous manometry, where I'm measuring the pressure. So what I take is essentially an arterial line cable. I zero it, and then I'm able to zero this as if it's a CVP waveform or an ICP waveform on the anesthesia monitor. And actually in my suite, I have that directly projected to my my interventional screen. So as I'm looking at the venous anatomy, I'm tracking and pulling my catheter around the venous anatomy, and I'm seeing what that waveform looks like, as well as the absolute pressure, and put that in my note. So here are all the different places that we measure. I measure the superior sagittal sinus, torcula, bilateral transverse sinuses, usually both the midpoint and the medial, then out to the transverse sigmoid junction, the sigmoid sinus, the jugular bulb, and then the internal jugular vein. So I usually go from the right side all the way up across the torcula and down to the contralateral internal jugular vein, or at least the contralateral jugular bulb, and then measure all the pressures backwards. Then I try to create something like this. This is a 3D venous rotational venogram. And then I show what the pressures are like at each of these particular spots. And then in this particular case, you can see an example of where the venous stenosis is, or some large arachnoid granulation in this case. And then I would share this image with the referring physician. For me, in my practice, it's usually my neuro-ophthalmologist who sends most patients to me, but many patients find me directly as well. So I'm a big believer in not just doing a digital subtraction angiogram or venogram, but also doing cone beam CT venography. So basically, this is the typical 3D that you've all used, perhaps for aneurysm surgery or other endovascular procedures, but doing that study on the venous side. And so if you're interested in doing this, I've written on this topic, specifically discussing rotational venograms a few years ago in Journal of Neurosurgery. And there's a couple tweaks that you make from your normal arterial injection protocols to be able to create these kinds of pictures in the venous phase. And so this is particularly important. The same way that we think in 3D anatomy on the arterial side, we have to think in 3D anatomy on the venous side to be able to diagnose some of these issues. So if the patient has symptoms that really fit, you need to be dogged about looking for the causative lesion, whether that's an arachnoid granulation, extrinsic stenosis, intrinsic stenosis, or small kind of webs and granulations within the vein that can perturb or limit the flow. So here are the pictures. That was 2018. This is what we're creating in 2022, 2023 now in my practice. The imaging quality has continued to improve, and we're able to see this truly beautiful venous anatomy. Now we can see that the endovascular angiographic techniques are catching up to what we see and appreciate the beauty of the venous anatomy under the surgical microscope. So you can see all of the collateral veins here that are in place. And sometimes this can even be, I don't generally do this before a microsurgical operation, but I certainly do study the veins on the angiogram to appreciate if I'm doing a transsylvian approach. Do I expect the deep cerebral veins to be, a little bit more dominant? Do I expect to see a frontal basal vein that I won't be able to sacrifice, during a deep approach, etc. So we can identify, I think this should spin around. We can identify this in 3D space. And in this case, you can see, measure some of the venous stent parameters, the size of the veins. This is so much easier to do in 3D space than what we were doing previously on just two-dimensional DSA. So here you can see this is a video. Hopefully the videos are playing. Please let me know if they're not. So you can see that the microwire has crossed here. We've crossed the stenosis, in which, in this case, it was actually by the right-sided transverse sigmoid junction, taking a microwire and a microcatheter across the torcula and then all the way to the contralateral jugular bulb. The microcatheter tip here is in the left jugular bulb, as seen in the AP projection, and we are now going to work our way back, transducing the pressures at each point. Looking in biplane angiography, you can see now the microcatheter has been pulled back to the torcula, and you can see that the guide catheter is positioned here in the jugular bulb. Now, I mentioned that some patients have this extrinsic stenosis versus intrinsic stenosis, and so this is really a chicken and the egg problem. So one of the things that we're starting to understand now, but it's still an area of debate and I would say partial understanding, is when do we have venous outflow obstruction related to an intrinsic, something within the venous sinus stenosis, but we think that this can be a primary cause of IIH. So rather than being truly idiopathic, maybe the issue in and of itself is the venous outflow obstruction. So for example, for non-obese patients who don't have that initiation of that vicious cycle that I showed before, these patients, maybe they have some anatomic issue of venous outflow obstruction that then starts the cycle. So their cycle does not start with them being obese, for example. This was a study by Dr. Vitor Pereira. He presented this at ESMINT, at the ESMINT meeting earlier this year. And so in this study, they looked at 400 patients, I think, who were getting non-invasive imaging for pulsatile tinnitus. They had both MRI plus ophthalmologic assessments. So you can see here, they have many of the other things that we see in IIH, but these were non-obese patients. And so they're having the empty sella. They get tonsillar descent or a Chiari malformation. They have enlargement of Meckel's cave bilaterally, and that, especially CSF pushing into Meckel's cave, for example. Or we see some tortuosity or displacement of the optic nerve, especially within the eye or within the orbit, or protrusion of the optic nerve head. So those are patients that you would want to evaluate further, even if they don't say have the classic kind of symptomatology, but they have some of the symptoms of IIH. So now we've done the venous manometry. Now who's a good candidate for stenting? So what I do is I do my venous manometry. I do it awake as an outpatient procedure. So I discuss with patients that we're going to do this venous manometry. I'm going to study the angiogram and do those reconstructions. And then I meet them within the following week, a few days later. I review those images with the patient, and then I discuss whether they are a candidate for stenting. If it's a slam dunk, then I would start the patient on dual antiplatelets while I have the discussion for considering for them for stenting. So I expect them to have a diagnosis of IIH or truly disabling pulsatile tinnitus, something that wakes them up, something that prevents them from working, something that is really inhibiting their quality of life. Mild pulsatile tinnitus can have a variety of other causes, and those patients should really be seeing ENT or undergoing some other workup. But severe pulsatile tinnitus can really be something that affects quality of life significantly. Now, usually for IIH patients, I like for them to have failed some sort of a medical management That's usually 2. I take that from the epilepsy surgery literature, where I consider failure of medical management or failure of relief from medical management to be they failed Diamox and they failed one other agent. That second agent can be something like Depakote or topiramate, usually as the 2 first-line agents, or perhaps a diuretic like furosemide. So I want them to have failure of symptomatic relief. Some people, just the side effects from Diamox can be so severe that they're unable to tolerate it. And I don't know if any of you have taken it. I've taken it myself while hiking for treatment of altitude sickness. And it's not a benign drug. It in and of itself has plenty of side effects and cannot be fun for patients always. I like to see a pressure gradient for greater than 8 millimeters of mercury. So the larger the pressure gradient, the more confident I am in that I can help the patient. And then ideally focal stenosis. You don't want to be stenting an atretic sinus. That can be both technically difficult and something that can lead you into complications such as rupturing a vein or very difficult microcatheter or guide catheter access. And that's something that you should be very, very careful about. So you want to see focal, ideally very focal stenosis, multifocal stenosis, or we have like tandem stenosis, 1 focal stenosis upstream, 1 downstream, totally reasonable to stent the whole segment. And we can talk about that later, but really the more focal it is, the better. Now, here's the overall experience. This is not my experience, but this is the largest meta-analysis series shown here at the bottom. By Dr. Brzezinski. So this is 474 patients in the meta-analysis. This is what I cite to patients, high 80s to 90%. So papilledema, something that's definitely almost always going to improve. Headache, a little bit less so, 80% nearly. And then pulsatile tinnitus, about 90%. So the patients who have headache, they do have sometimes a rebound headache or a headache after the procedure or partial improvement of their headache. And so that's okay. If we can at least get them partial improvement of their headache, and then the remainder is taken care by a reduced dosage of their medications, or they're at least able to function a little bit better and then start to exercise and lose weight. It starts it back getting out of that vicious cycle that we talked about. Papilledema is obviously the most important function that we try to save. And I mentioned most of my patients are coming through the ophthalmologists. Pulsatile tinnitus also, you can really guarantee that it's going to improve. The more severe the stenosis, the more likely it is to improve. Overall, major complication rate, intracranial bleeding, and death is something that has been described, 2%. I have not, knock on wood, personally seen it in my experience. And I think the more cautious you are about your patient selection, really using a careful wire technique, respecting the veins, then you can leave yourself out of trouble. The way that this generally happens, intracranial bleeding, subdural hematoma, is puncturing of a vein while trying to cross something too aggressively, generally with an 035 glide wire. So I try to use microwire technique as soon as I can, transition to that. And then just being cognizant of your local anatomy. Don't let the wire float where you don't see it. Don't let the wire float and make sure that you have road mapping of the veins that you need to see so you can protect it. About 9% of patients, 1 in 11, will require a repeat endovascular procedure. Again, I have not done this in my practice because I tend to be aggressive about stenting across long segments and really trying to obviate the issue of adjacent segment stenosis or restenosis. CSF diversion, so essentially eventually needing a shunt, is only eventually needed in about 3% of cases. So pulsatile tinnitus, I'm starting to do more of these. You can see it. If you ask the patients, IIH patients may be coming to you with primarily visual symptoms, primarily headache. But then if you ask them, many of them do have pulsatile tinnitus. And you want to see usually that it's ipsilateral to where the more severe stenosis is. It's a pretty good lateralizing symptom, but sometimes it can be bilateral. So you can see here, I showed in the other series, here is 85%, in the other series, 90% improvement of that pulsatile tinnitus. Now, how do I do this? Here's what I call the armamentarium. So I look in my angio suite, and I choose all the tools that I need, and I'm ready to go. So I think of this just as in surgery, you need to know your tools, which tools are the best for the procedure. So I usually like to do an upper extremity transvenous technique. That means I go through the antecubital vein in the arm, or the basilic vein, a little bit more medial in the arm by the bicep. And when I do a manometry procedure, so when I do the initial procedure, I do it the same way. And so that usually tells me whether or not this is going to be feasible. Some patients don't have a large enough vein there, or some patients have difficult arm venous anatomy. For example, a woman who has had breast cancer, for example, may have had some issue with the subclavian vein that you're not able to transgress or traverse, rather. So that's what I used. And then if you need to go through the femoral vein, totally fine. This is just a matter of something that is nice for not having to puncture a deeper vein in an obese patient, to be honest. I use an 8 French short sheath. I use this particular guide catheter, which is both trackable and quite stiff and supportive. I put a diagnostic catheter inside that, a glide wire that has a back end that's stiff, but a distal end that's very floppy and soft, a microcatheter, a micro wire, and a so-called Zilver stent. The Zilver stent is this stent here. It's very, very radio opaque. It's very easy to see. It has a beautiful construction, as you can see here, that is very resilient on the outside. It's quite strong and similar to the carotid stents, but way more trackable and easy to get a large stent up to 1 centimeter through what's relatively small 088 guide catheter, or even down to an 070 guide catheter. And finally, it's very, very trackable. So here's what that looks like. I learned this technique essentially in practice. I generally learned a transfemoral technique in training, and then I saw this paper published a couple of years ago by my colleague, Dr. Abakasis from Louisville, Kentucky, and I just called him and I said, "Hey, I'd like to try this out," and he walked me through it. Very, very easy to do. So if you haven't done this before, don't hesitate. What I would suggest is you start with your anesthesiologist, kind of placing a simple IV, have them place a large bore IV, ideally 18 gauge or bigger, into the cubital vein, antecubital vein, or the basilic vein. And then you just exchange that over a wire for a larger sheath, up to an 8 French sheath, as I showed. Eventually, after the first time doing that, I said, well, that's pretty easy. If the anesthesiologist can do it, so can I. And now I just do a simple ultrasound guided technique, micropuncture, and get this access. It's very quick. And now my fellows are very facile with that as well. Here's what that looks like here. This is the placement of an 8 French sheath. This is very, very big, but the antecubital vein is plenty capacious to be able to slide that in. That's what that looks like. And then gives you tons of space to be able to do these large bore interventions. And then all you have to do is put some pressure. I keep 5 minutes of pressure at the end, and then just wrap the arm, just as if the patient had given blood for a blood donation. Here's what it looks like. You can see crossing. The jugular bulb is the most difficult place to cross. It's kind of very tortuous and takes turns in multiple directions. And so that's what you have to do here. You get across with a microcatheter. What I actually do is I advance the guide catheter all the way across the stenosis in a Seldinger technique. And if you can do that, then unsheathing the stent is very easy. Here's what that looks like. This is coming from the arm. You can see that we're coming from the subclavian vein. I've crossed with a wire. This is my insert catheter, or the diagnostic catheter that's crossed here. This is an 088 catheter, pushes across. You have to kind of tap at it sometimes because there can be valves in the more inferior part of the internal jugular vein that we're seeing here. And you just kind of have to push through with timing. And at times I also use control of the patient's breathing, whether having them take a deep breath and allowing the venous flow to come down, then the valve opens and I shoot up. Here's me tracking the guide catheter now across the stenosis. I'm going to have this large bore catheter all the way up in a very controlled manner here, up. This can get even up to the torcula and in the inferior suprasagittal sinus, or rather the posterior suprasagittal sinus. Again, you have to really make sure that you understand where these veins are. Don't let the wire go where you can't see. Now we have this here. I'm going to show that AP view here. The stent is being unsheathed at the transverse sigmoid junction. You can see that the stent is coming into view here. You can actually see where it's pinched. It's a very, very radio opaque stent, beautiful stent, where you can actually see exactly where it opens across the stenosis. Now look at that view in lateral, and you'll be able to see the slight pinching right at the transverse sigmoid junction. And that's what you want to see. Now that slight pinching, generally you don't even need to do an angioplasty. The stent is strong enough to keep it open, and it doesn't need to be 100% open. Right there is where that microstenosis is. Okay, so now I've tracked my guide catheter back through the stent, and look at this injection. You can see that it's wide open. A minor deflection of it right there at that point. You can also see it on the AP view where that stent is a large stent and able to have a lot of radial force to open up the stenosis. So now you've done a great case. What do you do? So I would suggest that people read this book. This is a great book to read and is available for trainees digitally for free, actually, about how to build a practice and kind of communicate with your referring physicians. And so regardless of how you get paid, this is maybe a little bit more US centric in terms of how we are reimbursed for our cases. But how do you communicate with referring physicians and others in the hospital about the great work that you're doing, and then start to build your practice and get referrals? Well, I think it's important to show your work. So I mentioned that I started doing this sort of advanced venous cone beam stuff to create these pictures. I studied this back as a resident and learned to create these images. Well, now in practice, I've moved to the next level of that. This is a great study recently by the NYU group calling this Super Dyna. So Dyna is the Siemens brand for cone beam CT. Expert CT is the Philips brand, and every angiographic system has this capability. But you're fusing two different 3D images to show both the vasculature and devices. And so please contact me if you'd like to learn more about how we do it. But I've basically taken the Super Dyna concept from NYU and applied it to the venous anatomy, and this is how we do it. But these are the images that we've started to get. This was maybe 6 months ago when I started to do the stent, and I can show the patient exactly where the stent is, where the stenosis was. But I've gotten to go even more in detail to really be able to show both the patient and the referring physician, so people really understand that we are able to start curing IIH in many patients, or at least significant relief of symptoms. You can see how this is really beautifully following the inner table of the calvarium and where the sinus stenosis was and how it's opened. Beautiful anatomy of the stent itself, the Zilver stent I'm showing here. And then you can see the venous anatomy that's been opened, spinning that around. So in conclusion, I think venous sinus stenting, we can say in a very evidence-based manner, and this was these are conclusions from a large database study that I did. We can show that it really alleviates headache, visual disturbances very reliably, especially papilledema, less so visual field defects, dizziness, and tinnitus. These are all things that improve when you stent patients with a refractory IIH. Venous sinus stents decrease the need for medical treatment. So usually after stenting, we're able to come down on medications either completely or a dramatic decrease in their dose. So patients who are having side effects from their medications, we can offer them some relief. And then the patients who have a venous pressure gradient, so high pressure on one end of the gradient, low pressure on the other, these patients really should be considered for stenting, especially those who have side effects from their medications. I'd like to acknowledge, I stand on the shoulders of those who taught me this technique, both at Barrow in my fellowship and Dr. Peter Can, especially in my residency. And then my senior partners here at Penn, including Dr. Burkhart and then I do all of these procedures with my 3 excellent fellows. And here at UPenn, that's a very multidisciplinary effort. So Dr. Al-Khatib is a radiologist, trained in diagnostic radiology. Dr. Kandergula has trained in microsurgery skull base and is now learning endovascular. And Dr. Flesher is a neurocritical care trained. And so all of these 3, neurology, radiology, neurosurgery, have come together now in our department training in endovascular techniques. Thank you.
Thank you very much, Professor Srinivasan. It is a great lecture, and it is a very nice explanation for the treatment of IIH. So, we will open the discussion and the questions. Do you have some questions or?
Yes, I would like to ask one question, if you permit. Well, Dr. Srinivasan, that was an excellent lecture, and thank you for taking us through the various pathology of the IIH. And you showed very beautifully how you do this procedure, which is very important for young neurosurgeons to learn. And one question that I would like to ask you is regarding the pressure gradient. You showed in your case that you showed in your lecture that you generally prefer a gradient of more than 8. I'm asking this question because most of the people doing the older generations are a bit skeptical in stenting where there is pressure gradient is medium between 5 and 8, and also where a gradient is less than 4, which is low pressure gradient. And to bring into your attention, of course, you might have read the recent paper from Texas, which came out in November 22 in neurosurgery, where they have showed good outcome in patients with stenting, even in where the pressure was low, less than 4.
Right.
So, do you always stick onto this value of more than 8, or have you seen good improvements in patients with low pressure gradient as well?
So I've done a couple in the like at 6 and 7. I haven't gone less than 4 in what I've done so far. I did see that paper. I think that we can certainly consider patients for stenting in that medium range, but I don't like to be the only physician who is seeing those patients. So like I said, some patients come to me directly because of they've either heard some talk or direct patient groups. Many of these patients are on a Facebook group together and hear about venous stenting and come to us directly. So in those particular cases, I like to make sure that one of my colleagues has seen them, somebody who can verify the diagnosis and make sure that I'm doing it for the right reason. And then in those cases, if I know that the diagnosis is definitely true and they have something objective other than just the headache, let's say, something objective with their visual field defect or papilledema, then I would certainly consider it. And so, it's they don't need to fulfill every criteria, but at least if they have this slightly lower gradient, I would at least have them want to see checking off some other boxes before I consider stenting. So it's not off the table for me, and particularly as patients get more desperate, either from their symptoms or I see that they're objectively losing vision, then I don't want to keep them away from a treatment. One thing to consider, especially for patients with active vision loss who have this medium gradient, is if you stent, you have to keep in mind that they're going to be on the dual antiplatelet therapy for some time. Now, you can shorten that therapy to probably as little as 6 weeks. I do it 3 months of dual antiplatelet therapy. But let's say that you stent a patient and they're not getting better well enough, and they're continuing to lose vision in the setting of a low gradient stenting. Well, now you have to consider, will you do an LP on this patient to temporize them? Will you put in a shunt on this patient? And now they're, going to be on either dual or at least single antiplatelets. And so, I try to be a little bit more cautious about understanding that. And so some patients, not me particularly, but other practitioners have suggested, let me shunt them up front and then I'll stent them in addition, or stent them if needed, something like that. Reverse that order of operations, if you will.
Thank you. Well, I would like also to ask the same question to Professor Miyachi. What is your threshold for stenting, the pressure gradient?
Yeah. So it is so very important point. And I have one case with a lower gradient case, but I put a stent, and it is a dramatic improvement. So I think even in the less than 8 millH lower gradient, I can try it. I can try it. Yeah. So I think it is severe symptoms, for example, papillary edema or the severe headache. That is important. And also maybe the intracranial pressure is very, very high. Stenting is sometimes very effective. So I think I don't have an importance for the pressure gradient. That is personal opinion.
Thank you very much. Yes, any questions from my co-host, Dr. Liu Boon Seng?
Thanks, Dr. Visha, for very nice lecture. I wonder, I have about three questions, Professor. First is, how safe do we do a lumbar puncture in a patient with diagnosis of papillary edema, especially when you do a venogram showing obviously there's a venous obstruction, because we used to do in my center previously on ventriculostomy with 24 hours monitoring. So may I know the risk of doing such procedure? And my second question, Professor, regarding, because we used to see unilateral or asymmetrical of the transverse sinuses. So in your opinion, what makes some people with so-called IIH syndrome or diagnosis, or some without? And then how do you think that those without IIH symptom, the asymmetrical do not have a pressure gradient? And or you also look into the tinnitus must be ipsilateral to the smaller venous outflow to diagnose, or you purely use imaging to diagnose venous outflow obstruction diagnosis, Professor. And I think I leave to two questions. Thank you, Professor.
Thank you. Very good questions. So for the first, in terms of safety in papilledema, I think to take out 10 cc's in a controlled manner, but I have not seen issues, and seems to be fine. The main concern is them developing an occult CSF leak or needing a blood patch because they overcorrect. And then what happens is that you let's say you diagnose a high opening pressure, but then the patient's essentially, it's no longer a therapeutic tap. It's actually, they overcorrect their ICP. Their ICP drops for a few days because they're persistently leaking CSF, and then they're complaining to you about headache. And so that discussion gets clouded in that situation. So I try to be relatively pretty controlled about it. I think being careful with I actually like to do a slightly paramedian technique, where I think that seals up better than going directly in the midline. And so I do that in the radiology suite. And then finally try to use a smaller needle. And that tends to be, a very careful atraumatic technique. And so it's not just about, can you get into the thecal sac, but do it really as perfectly as possible. Right. So of course, there may be limitations to what's available in your center and maybe between departments, but I think that that's the best way to do that. And also, if you can directly talk to the patient very soon after I basically will give them 48 hours after a tap, and then I do a phone call or video call with the patient to discuss with them what the results of their tap were. And so then I can help guide whether or not I want to proceed with the venogram, and I usually do. Then the next question was about the different kinds of people with asymmetric venous stenosis or differential dominance, things like that. So often it's very common that people will have one partially atretic or partially developed sinus, and then the other sinus is dominant, but has a focal stenosis. So it's funny because the patients just want to take care of everything. They say, step me both sides, right? But of course, I think it's important for us to be judicious and careful about it. It's very rarely needed. And I tell them we can always come back in the future. I will do another manometry on you in 6 months. Let's understand what the changes in the venous pressures have become, how you've adjusted for it. And if we need to stent the opposite side, so be it. But I try to look for what's easily accessible for me technically, what is as focal as possible, and which one has the greatest gradient. And so somewhere between those 3 points, I will understand what's the more favorable one. And so that may be the right, that might be the left, and it just depends. And so you had one more.
Yeah, one more last question. What's the success rate, and how many % of patients eventually you still need a CSF diversion procedure, Professor?
I haven't done one yet. So in a patient that I've stented, I have not done it yet. And so, but I've certainly done it in patients who, for example, did not meet the criteria. So people who had low gradients but high OP, I go ahead and just directly have shunted them. We saw in that larger paper, I mean, this is why it's important to do these multi-center studies or database studies, is as many as I do about one every other week now. That's still not going to be enough for me to individually tell. And so power and numbers for sure. And so 3% seems to be about the rate of CSF diversion need.
Thank you very much, Professor.
Thank you. Yes, our friend Dr. Ben has joined from us from Hong Kong. Ben, any questions from you?
Yes. Thank you so much for this very interesting topic. Also, kind of this not very often, but occasionally encounter this disease. My question is that firstly about the diagnosis. I do encounter cases with normal pressure with clinical symptoms of intracranial hypertension, but LP findings was normal. So usually, do you have any experience, and how do you how would you consider this phenomenon in patients with a normal LP finding but with clinical features of intracranial hypertension? And my second question is about for those with bilateral, some do have bilateral transverse sigmoid sinus stenosis. So usually, how would you manage? Which side would you consider operation first, or you consider operation on both sides, or the dominant side? So thank you so much, and it's indeed a very interesting topic and very excellent result from your center.
Thank you, Ben. So for the first question, patients with a normal opening pressure on LP, or let's say very mildly elevated or even completely normal, that can certainly happen in patients, skinny patients, perhaps, or even some larger patients. And so it's a great question because I have one coming up on Monday, where exactly as you described, the same scenario, very significant symptoms. She has visual obscurations, and things seem to match up otherwise, but a normal LP. So what I said is, and I haven't encountered that very frequently, but I think this might be the most obvious case of that. I've done a few with like mild elevations. And what I've seen is there can be a mismatch between what we measure as the venous pressures, let's say in the superior sagittal sinus and central pressures, and what we measure across the gradient and the opening pressure. So if the symptoms match, I think it's totally reasonable to go ahead and do the venous manometry and the venogram, look for an angiographic stenosis, and then look for a focal gradient if you can. And so what I expect in this patient is that I will see, I think she said her OP was about 20, or maybe just 18 or something. And so what I will look for is, something that is higher than that, and then a gradient. If she drops by 6 points or something like that, I might still consider stenting her if I see a true angiographic stenosis. And so you have to look very carefully, and that's why I made the mentions of the the cone beam CT and looking very carefully, you have to look for the cause very deeply before you write off the patient and say that they're not a candidate. So as for your second question, patients with bilateral stenosis. So again, it's usually three factors for me. So what is technically easier? Well, the right side tends to be technically easier when I go through the right forearm as a right-handed surgeon in our angio setup. But totally, it's not hard to go up the left side. I would go femoral most likely if you're going on the left side. And then prefer the side of dominance if I can tell which side is dominant. And you can kind of look. That's why it's important to not just look at the venous side, but the arterial side and see which way that it's starting to, which side each hemisphere is using it. Look at the posterior circulation injection as well. So where's the occipital lobe draining? Which side is labae on? All these kinds of things. So you kind of put that all together. So ease of technical feasibility, level of the gradient. So more points of drop, as well as dominance of the sinuses.
Thank you so much, and really congratulations on your results and cases. Thank you.
Thank you.
Thank you very much. We have a question in the chat box from Daniel Encarnacion. You may ask your question directly.
My question is about because this idiopathic hypertension, what do you prefer, the BP shunt or LP shunt to statin? Because normally this kind of patient an overweight is frequent in women, no? And if you use bypassing this kind of patient, gonna be decrease all the symptoms. But first, we need to perform the BP shunt to see any response, or is the patient had optic nerve pressure, papilledema? We need to perform optic shed fenestration, or including the neurosurgeon can manage this, or need to refer to ophthalmology department or work with the ophthalmology department to perform these precisions.
Okay, I'll answer your first question first. So you're right, and yeah, we generally tend to see this in younger, overweight or obese women, and I think we don't quite understand the really underlying etiology of this. There's probably more to it than we think. So there probably is some link to the endocrine dysfunction and or lymphatic/glymphatic. So there are some studies that are being done now. To be honest, not that I'm quite as familiar with, but I know that they're ongoing and have been published. So worth a read. And we know that the most durable treatments is still bariatric surgery. And so if patients lose a significant amount of weight, the symptoms durably disappear, and it can be very, very helpful. But the problem is many of these patients, they're so disabled by the disease, they're not able to undergo good weight loss. They're not able to go exercise despite their best efforts. And so sometimes the role of venous sinus stenting or a shunt can be to break the cycle, get them into a more functional state, and then they're able to at least consider something like bariatric surgery, which is a major undertaking, or at least pursue weight loss on their own. And many of these patients are able to. They were able to tell you a time in which they were lighter weight and had no symptoms. And so we need to try to help them get to that point. So that's kind of for the bariatric side. Now, in terms of how I consider that, I didn't talk about shunts too much, but basically, sometimes patients get referred to me for a shunt, but I'll tell them, well, let me offer you something else first. Let's look for a possibility of a stent. And this is definitely less invasive and way more beneficial than a shunt, to be honest. And so the only downside is in a patient with a low gradient who may not immediately benefit, but would benefit from a shunt. And you don't want to take that potential away from someone who has rapid progression. That was the kind of scenario I mentioned when Dr. Raja was mentioning a patient who might be rapidly progressing, for example. So those would be the only patients that I would consider maybe a shunt up front. But, you ask any patient, they'll take a stent any day of the week compared to a shunt. It gets them back to work quickly. I mean, the majority of my patients I do these a lot on Thursdays. They're back to work on Monday. Working as, I've treated nurses, other people in the hospital, and they're back to work on Monday lifting patients. I mean, it's great. And I've gone through their arm. I mean, it's just like giving blood. They may sometimes complain more about the Foley catheter than my intervention. So I think that is definitely my first line is stenting. And then if needed, definitely, I don't think it's bad to do a shunt. After all, I'm a neurosurgeon. I've done plenty of shunts and do plenty of shunts. And between the two, I would prefer a VP shunt over an LP shunt just because of the general ease. Unless they have particularly slit ventricles that are very, very small, then I do a VP shunt if absolutely needed. But the rate of shunt failure in these patients over the course of their shunts, remember, you're putting a shunt in a 30-year-old, right? Or a 40-year-old, they're going to be living with IIH for a long time. And so the long-term shunt failure rate is somewhere in the 48% range or more, whereas we're talking about a 90% success rate without needing any other procedure for a venous sinus stent. So that's definitely their preference. If they have primarily optic nerve issues without headache, without tinnitus, and it's really mostly in the visual system, then optic nerve sheath fenestration, that's where it really shines. But again, those patients often need multiple treatments, multiple ONSFs. And I don't do them personally. I generally send them to my ophthalmologist. But I think if you have good endoscopic capabilities and you're familiar with it, then by all means. But I think they're probably very slick at doing it. They do it as an outpatient. Yes, I'm comfortable drilling out the optic nerve and opening it for, a tubercular meningioma or something like that. But I would rather not do it the way that I'm comfortable with it. Let them do it through their small little holes.
Well, thank you very much. So now we come to the end of this session, and I would like to invite Professor Miyachi to say his concluding remarks.
Okay, thank you very much. May I have one last question?
Please.
One question. Yeah, the post-stenting management. You talked a little in the previous comments, and you use 6 months antiplatelet because 3 months. Yeah, we usually use anticoagulant because this is a venous devices in the venous side. Which is better? How do you think?
The data seem to be pretty equivalent both ways. I mean, whether you use anticoagulant or antiplatelets, essentially a venous stent thrombosis, the rate is like nearly zero. It works no matter what. Dual antiplatelets do seem to be better than single antiplatelets from the small series that have done single antiplatelets alone. I probably imagine a scenario in which we have coated stents, similar to how we have coated flow diverters now. And if you take that and you put it in the venous system, it's going to be so low risk that maybe you get away with very, very little. There's already, for example, heparinized coated devices that are used in the peripheral vasculature. I think there's a Viabon heparin eluting stent, for example. And so if we have something like that comes in the sizes that we need it for venous stenosis, maybe you're able to get away with nothing. But also in the US, at least, the cost of the medication, so the cost of aspirin and clopidogrel is pretty low and pretty easy to get. I don't really even care about platelet reactivity testing because even in non-responders, it's such a minor issue compared to when we're in the arterial system. So I think it's fine. In the US, the novel anticoagulants, for example, Eliquis, so what are the like rivaroxaban and all of these other kind of newer anticoagulants are way more expensive. And Coumadin, I would rather not have to worry about a patient being hypertherapeutic and getting checks. So at least within the US, that's kind of seems to be the equivalent. But I agree with you. Theoretically, venous system anticoagulation, but that's how we have it practiced.
Okay, I get it. Yeah. So thank you very much, as a Professor Srinivasan. This is a very wonderful lecture, and it's a very nice and very valuable discussions. It's a very fruitful time. Thank you very much. Okay.
Thank you. So I'll, if I may, just one last comment. So especially for residents and fellows in the audience, I want to encourage you to think of this as a neurosurgical disease. This is something that has often been pushed and in the realm of neurology, ophthalmology, and when we are consulted, we prefer not to take care of this. Right? We prefer this is a consult I used to dread as a resident, but now that we have this tool. This is an excellent operation. It's a fun operation. It's something that I enjoy seeing these patients improve. It was just a disappointment to do the shunts and have them come back with shunt failure over and over and over. I can imagine all the patients I remember seeing in residency. But I encourage you to think about these problems. Consider research in this field. It's something that is only going to advance with time and actually really should be treated by neurosurgeons. So I encourage you all to think of it that way.
Well, absolutely spot on. Thank you very much for these wonderful comments and lecture. With that, we come to the closing session of today's webinar, and I would like to officially close this on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Toshio Matsushima and Dr. Vishi Srinivasan, as well as both the chairs, Professor Uyghur Ture and Professor Shigeru Miyachi, for their wonderful time and support for the ACNS webinars. I'm extremely grateful to Professor Shubin for broadcasting this on the WeChat, YouTube, and Zoom. And as I mentioned earlier, there are more than 1,250 audiences who have joined us live on all three platforms. And special thanks to my co-host Liu Bun Seng as well as Ben, who's joined us from Hong Kong. So until we all meet online tomorrow, it is bye-bye from all of us. So thank you very much for joining.